If you struggle with chronic joint, muscle, or nerve pain and you're being medicated to treat these symptoms by your doctor, you're going to want to check today's show out. We're going to talk in detail about the vitamin and mineral deficiencies caused by many of these common medications doctors prescribe. We're also going to do a deep dive on how these vitamin and mineral deficiencies can actually recreate your pain, making it worse and preventing you from actually ever healing. This is a show you're not going to want to miss. Stay tuned. We'll be right back. You unlock this door with the key of compassion. Beyond it is another world, a world of science, a world of common sense, a world of sanity. You're moving into a land of both empathy and ethics, of nutritional knowledge and empowerment. You've just crossed over into Dr. Osborne's zone. Hey, welcome to the Dr. Osborne Zone. Today is part 2 of our special series on drug-induced nutritional deficiencies. Now, today we're going to be talking in depth about medicines that are commonly prescribed to treat common aches and pains, including arthritis, muscle pain, nerve pains, diseases or treatments for neuropathy, and other types of related pain diseases. So if you struggle with pain and you're being managed, if you're seeing a pain management doctor, if you're seeing a general doctor who's prescribing you drugs to treat or manage your pain, this is the episode you want to make sure you watch to protect yourself and to protect your nutritional levels. So let's dive into some statistics first and foremost on pain. I think it's important to kind of bring scope to this conversation because many people think the medicines that are being used to treat their conditions are relatively benign, meaning there are no tremendous or horrendous side effects that are basically worrisome or that even need to be worried about. And a lot of times your doctor won't have a good conversation with you about the side effects. So he's just kind of writing the script, handing it over to you, just assuming you're going to get it filled, but there's no in-depth about the potential risks of these medications. So to put kind of scope to this conversation, I think it's important to quote the ex-CDC director Thomas Frieden. "We know of no other medication routinely used for a non-fatal condition that kills patients so frequently. We hope to see fewer deaths from opiates." That's the bottom line. They're really dangerous medications that carry the risk of addiction and death. Now that's just opiates. And we're going to talk about a lot of different kinds of pain medications today, but opiates are on the front line right now. They're a lot in the media and they're a lot on the news because of the massive deaths and addiction that they're causing. Now if we look at this diagram here, what you'll see is kind of a corollary between the prescribing patterns of pain-killing medications overimposed with the quantity of deaths of individuals per 100,000 people. And you can see these two curves, the green curve representing the sale of pharmaceuticals, the yellow curve representing the amount of deaths. You can see that the curves correlate almost identically well. And so this is good feedback for us to understand that the more of these drugs are dispensed, the greater the risk of deaths that occur as a result of these drugs. And we can also see here in the second figure, and this is coming directly from the CDC's website here. So the national drug-involved overdose deaths number among all ages from 1999 to 2001, the most current statistical data. You can see the top synthetic opioids is this gray line right here. And you can see how from about 2015, that gray line has skyrocketed. Now you can see some of the other drugs that are listed here, like benzodiazepines in green. Okay, they've kind of stayed relatively flatline, no major change there, although again, still risks of death. And then antidepressant medications, very, very common as well. These are oftentimes used to treat pain as well. They're pretty flatlined. You can see this bottom line that represents antidepressants. And then you can see here the non-synthetic opioids, our natural opioids in this darker blue curve here, which is indicative of this line right here. So it's really the big one that's increased the most here in the last decade or so are these synthetic opioids, fentanyl being kind of the main one. that's on the market, both legally and illegally. A lot of people and a lot of doctors have turned to these prescriptions to treat or manage people's chronic pain, making the claim that these drugs are relatively benign. However, nothing could be further from the truth. So I think it's you understand that scope. As a matter of fact, another maybe good homework assignment for you to do if you want to learn more about this is there's a book, a really great book called Dope Sick. If you haven't watched it or read it, it's a good one. There's also a Netflix documentary if you have Netflix or watch TV. So there's the documentary called Dope Sick and there's the book called Dope Sick. Either one is a great read. It'll help you understand the bigger scope of this problem. Now, even beyond the problem of just opiate medications, there's also just a major problem with medications in general. So this was a major study published a few years ago in the British Medical Journal. And one of the kind of the summaries here is that medical error is responsible for 251,000 deaths per year. And what does medical error mean? Medical error does not mean, oops, so much I made a mistake. Medical error can mean the doctor made a mistake, but this is also, medical error is also classified as proper treatment with unintended consequences. In this case, death, as being the third leading cause of death in the United States. So this was a study published in BMJ on the top causes of death in the US. You can see heart disease over here is number 1, cancer is number 2, but medical treatment is number 3. And I think it's important that you understand that, because so many times people go to their doctor and they just accept the drugs as treatment without questioning it, without questioning the safety, without questioning the efficacy, or without challenging for the potential for side effects. And because doctors today don't train in nutrition, there's no nutrition training in most medical schools, this is a topic you're never going to hear about from most doctors. I say most because some doctors do go and get postgraduate training on this topic and are versed in it and do the right things by giving their patients informed consent, but most do not. So, I mean, let's just ask the question of you guys watching, how many of you have gone to your doctor, been prescribed a medication, and your doctor sat down and said, hey, there are some nutritional consequences to giving you these medications, and we need to have a talk about that because this drug depletes X, Y, or Z nutrient, and I'm going to put you on those nutrients. How many of you have ever had a doctor sit down and have that conversation with you? Just raise your hand in the comment box. Say, yes, my doctor talked to me about it, or say, no, my doctor never mentioned it. Because when we look at these comments later, we're going to find that the vast majority of you are going to type in no. It's because it's not something that's commonly done. So let's look at some of the chronic use medications for, in this case, joint and muscle pain. So what we're looking at here, we're looking at common medications. One of the top classes, and this is an over-the-counter, so over-the-counter medication is can be still just as dangerous as prescription, in my opinion, even more dangerous, because when you're buying over the counter, a lot of times you don't get that conversation with your doctor because it's not there. You're just getting the drug or picking the drug up at the grocery store. So acetaminophen, also sometimes under trade names Tylenol, paracetamol, or Panadol. This class of medication used very commonly to reduce pain, also sometimes used to reduce fevers in individuals in acute fevers, but very commonly used for the treatment of different types of pains, muscle pains, joint pains. This class of medicine depletes glutathione. Glutathione is critical as a nutrient. It is the master detoxification agent for your liver. In other words, glutathione helps your liver take out the trash every single day. And if you don't have adequate glutathione, your liver can become bogged down. Remember that when you're depleting one of the primary agents that protects your liver, you're also subjecting yourself to greater reactions from your other medications, because many medications are metabolized by the liver. So if you're taking this chronically, depleting your liver, you run the risk of more side effects from the other medications that you might also be on. And so this is especially concerning, for example, in elderly patients who maybe they're on 5 or more medications, and this may be one of the ones they're taking on a regular basis. So glutathione is depleted as a result of using these medications. Something else that we know that research has shown us is that when people have selenium deficiency. Selenium deficiency. So selenium's a mineral. You can learn more if you want to learn more about selenium in depth. You can watch my master class on it. But selenium deficiency is very common in people with pain syndromes. There's a lot of research backing this up, that when doctors look at selenium levels in patients with chronic pain issues, it's very common for selenium to be low. So take that one step forward. When we have somebody with chronic pain who has low selenium and they start taking acetaminophen, the increased risk of liver damage is very much an issue. One of the reasons why this occurs is because selenium regenerates or recharges glutathione. It has a glutathione sparing effect. So when we see people that are already low on selenium start these medications, one of the big problems is there's a greater risk that now you're going to incur the liver damage. So be aware of that. If you're taking this for any length of time, you might ask your doctor not only to measure your glutathione levels, but also to check your selenium levels at the same time. Now let's move into this next class of medicines, these opiate drugs. There's a lot of different types of opiates: oxycodone, hydrocodone, codeine, morphine, fentanyl, methadone, all examples of these types of medicines. Now, to date, just to be clear, there have not been any major studies on directly this class of medication causing vitamin and mineral deficiencies. Not directly, but indirectly there have been. And the mechanism is through this right here. You can see this class of medicines causes appetite suppression. Now, appetite suppression is going to lead to weight loss, which we see a lot, especially in the people that are addicted to these medications. We'll see muscle wasting and weight loss. It's because they're not eating. So they're becoming malnourished because of that appetite suppression. And so it doesn't necessarily, again, it's not a direct deficiency, it's an indirect deficiency through reduced caloric consumption. So that's one of the problems associated with this class of medications. But one of the other ones is this severe constipation. Now, severe constipation, what happens there when a person's not having regular bowel movements? When you're constipated, your poop stays inside of you longer, okay? And why is that a problem? Well, if you have a permeability or a leaky gut, so if your gut is leaking and your poop stays inside of you longer, that means that the poop leaks through those holes, right? Those holes in your gut, and creates a major shift in inflammation. There's been a lot of research on this in the last 10 years about the microbiome and the types of bacteria in the gut and the certain types of chemicals that these bacteria can make. So if your gut is leaking and you're constipated, it's allowing for a greater degree of time exposure to those toxins having access to your bloodstream. Some of these toxins are called LPS. That stands for lipopolysaccharides. These are bacterial toxins that are produced in the gut. They're supposed to stay in the gut. These toxins are like what's supposed to happen in Vegas stays in Vegas, or what's supposed to happen in your gut with LPS is supposed to stay there, but if your gut's leaking, these toxins damage the liver. And they're known or notorious for contributing to non-alcoholic fatty liver disease and liver damage. And we don't want that, because if we're damaging the liver with mechanisms associated with taking these drugs, and we're taking more drugs that are also processed by the liver, we end up with more and more potential for side effect along the way, and that's just not something that you want to expose yourself to. Okay, so let's move into some of the other more common medications for chronic joint muscle pain. Corticosteroids. These are big hitters. A lot of doctors, when patients have like herniated discs or neuropathy or have intense, severe acute pain or post-surgery pain, they're going to get put on drugs like cortisone, corticosteroids, prednisolone. These medications are notorious for creating massive nutrient deficits. You can see here over to the right, calcium, potassium, magnesium, chromium, zinc, selenium, vitamins A, C, and D, as well as vitamin B12. All those deficiencies have been associated with chronic use of steroids. And so, problem with that, there's several problems with that. One of the problems associated with it is what we just talked about on that prior slide, which is the selenium, right? I said that those that have selenium deficiencies that start taking drugs like Tylenol or acetaminophen have a greater risk of liver toxicity or liver damage issues, and these steroid medications deplete selenium. Now, it's very common to see doctors write a prescription for a steroid, but also for acetaminophen. And it's also very common to see doctors write a combination of not just one, but multiple of these. So NSAIDs plus acetaminophen plus steroids. This is not an uncommon combo. And sometimes it's, you know, I know my son who's gone through dentistry school, is now a dentist. As he was going through school, they were discouraging the use of opiates for the pain management in dental patients, and they were really hammering and recommending the combination of acetaminophen plus non-steroidal anti-inflammatory drugs. And so again, these drugs are oftentimes given in combination, and that's another important factor that you want to take into consideration. But again, back to steroids. Steroids deplete all of these nutrients. We know that, for example, magnesium deficiency can increase pain. We know that potassium deficiency can increase pain. We know that calcium deficiency can increase pain. We know that chromium deficiency can increase blood sugar, leading to slower healing. Remember, why are we on these pain medications? The pain medications are generally given because somebody's got trauma or injury or some type of chronic inflammation that's leading to the perception of pain, and these individuals aren't healing typically. So when we take a drug that reduces nutrients, and those nutrient deficiencies have an impact on how quickly or how effectively that person can heal, we're getting stuck in a trap. It's like a loop, right? You take the drug to treat the symptom then is suppressed, but the drug creates nutritional deficiencies that lead to new symptoms that create either the same problem that's being treated or create new problems that would interfere with the primary problem that was being treated in the first place. So again, it's a trap, it's a loop, or a trick. I like to call it a trick because although, look, I'm not opposed to people using pain medications when they're acutely in pain. I am opposed, though, to the concept of pain management where those doctors are not looking at underlying biochemistry of nutrition, they're not looking at diet, they're not looking at lifestyle, they're not looking at any of the factors that really truly matter about the management of pain. And we're going to talk some more about that here in just a minute, so stick with me. Okay, let's move into NSAIDs. NSAIDs also cause nutritional deficiencies. Examples of NSAIDs: aspirin, ibuprofen, naproxen, diclofenac, celecoxib, or coxib. These are the kind of the classic drugs that many people gravitate to lower fever, but also just over the counter to remedy pain. A lot of doctors pull these out. These are sometimes called COX inhibitors. COX inhibitors are just a subclass of non-steroidal anti-inflammatories, but deficiencies that these particular medications can cause: iron, potassium, vitamin C, and folate. Now, it's interesting again, vitamin C deficiency causes increased pain. Folate deficiency causes increases in pain. Iron deficiency causes increase in pain, as does potassium, as we said over here. So a lot of these deficits are linked, again, to increases in pain, and pain is the very thing that we're trying to treat. So it's important that if you embark upon the use of these classes of medications, you're aware of these deficiencies, and that you either do one of two or even three things. Number one, I would suggest that, first of all, ask your doctor to test your levels nutritionally, right? Test for these things. Look at them, test them. Why? Because if you don't ask, you won't know. And if you don't know, you could be setting yourself up for chronic pain. You know, once the doctor gives you these meds, and if they don't work very well, the next step in that process typically is they send you out to a chronic pain management specialist, and now you're really going to get trapped because those guys, they never look at these things. They don't even acknowledge that these things are important. So you're going to be in a world of hurt, and you're going to become addicted, and you're going to have a lot of the long-term consequences of these medications. So ask your doctor to test your nutritional status. Number 2, properly dose or supplement with these different nutrients. If you know the drug is going to cause you to lose calcium and magnesium, then you should be on calcium and magnesium in an effort to try to override or to reduce the potential of that side effect with that medication so that you don't now pay the consequence of becoming deficient in those nutrients. The other thing I want you to understand about these 2 classes of meds in particular, beyond the nutrition, testing and beyond the potential for supplementation, these classes of drugs, when combined, okay, so steroids plus NSAIDs equals gut damage. Now, I just told you a moment ago that with opiates, right, we said that opiates cause severe constipation, right? And when that poop stays inside of you longer, if you have a leaky gut, then you have the potential for a lot more damage to occur through LPS and other toxins leaking into your bloodstream, creating chronic inflammation, subsequently creating chronic pain. So this is especially true of you that are on this kind of trifecta. Maybe you took some opiates and now you're trying to taper off those opiates using steroids and NSAIDs. These 2 drugs, when combined together, create massive amounts of gut damage. But even by themselves, steroids can create gut damage, and non-steroidal anti-inflammatories can create gut damage. Let's talk a little bit about that over here. So what I want to show you is just a little bit more in depth about that topic. So this was a paper published recently, Mechanisms of Damage to the GI Tract from Non-Steroidal Anti-Inflammatory Drugs. You can see down here, NSAIDs, or non-steroidal anti-inflammatories, interact with phospholipids and uncouple mitochondrial oxidative phosphorylation, which initiates biochemical changes that impair function of the gastrointestinal barrier. That barrier is what protects you from leaky gut. The resulting increase in intestinal permeability leads to low-grade inflammation. I think it's important that we circle that word, because what is causing the pain? What's driving pain in the first place? Pain is inflammation. It's very important that you understand that. And inflammation can cause a lot of issues, but predominantly it is an inflammatory process that leads to the perception of pain. And so here we are, we're talking about one of the very mechanisms of actions of drugs used to treat the pain, creating inflammation directly. We can also see here NSAID inhibition of cyclooxygenase enzymes along with luminal aggressors. Luminal aggressors would be things like bacteria, poop, LPS, results in erosions and ulcers with potential complications of bleeding, protein loss, stricture formation, and perforation. So what is bleeding? Bleeding causes blood loss. This is one of the reasons why we lose iron. This is one of the reasons why iron deficiency is a side effect of non-steroidal anti-inflammatories, because you're actually bleeding internally and don't know it, and that blood comes out in your stool, but it's already turned brown because it's oxidized by the time it hits the toilet. So that's that complication of bleeding, but also a reduction of protein. Now, what are your muscles and joints made out of? How do they heal and repair if they do become damaged? You have to have protein as an element. That protein contains the special amino acids that are necessary for healing and repair of damaged tissue. And so if you are creating a problem where you're leading to protein malnutrition as a result of the very damage of the drugs that you're taking to treat the very disease that's creating the pain, again, you can see how you're trapped. You get stuck in this vicious cycle. And I want you to be able to avoid that cycle. Now, speaking of cycles, let's talk about what I call the grainflammation cycle. This cycle, because we talk about what to do about it. So I'm here, we're presenting a lot of the problems, right? Like using the drug to manage the pain is, in my opinion, the problem. Well, what is the solution? Well, number one, it's identifying why the pain exists. For many people, the pain exists because of grain. That's hence the grain inflammation cycle. If you're not familiar with my work, if you're not familiar with my PBS special or my book, No Grain, No Pain, you should definitely check that out. We can put a link below and you can look more into that. But these concepts here, if you look at this funnel, you've got things like heavy metal, excessive omega-6, leaky gut, excessive carbs, mold, gluten, amylase trypsin inhibitors or ATIs, genetically modified organisms, and pesticides are all things that we know that come in grain. So grain contains all of these properties, and it's in big part, these properties lead to inflammation. Now that inflammation typically is why doctors prescribe pain medications, because many of these pain medications, what do? They either block inflammation, like the non-steroidal anti-inflammatories and the corticosteroid drugs, or they affect you in a neurological way. So for example, Tylenol and some of the antidepressant drugs and some of the anticonvulsant drugs affect neurological mechanisms that can suppress pain. So this prescription drug then leads to a reduction of inflammation, but it doesn't solve for why the pain exists, because it didn't take care of the things that were driving the pain in the first place. So now what you're doing is you're masking the pain. Well, back up to this diagram. When you have inflammation, one of the things your body naturally does is it makes more cortisol. Cortisol is your body's way of fighting inflammation. Cortisol from your adrenal glands, these tiny little glands that sit on top of your kidneys, make cortisol the hormone that helps fight inflammation, right? So when you're chronically inflamed, your adrenal glands will make more cortisol to try to help you out. When we make a lot of cortisol to deal with inflammation, or when we take prescription steroids, that induces muscle loss. It's a very known, very common side effect of chronic high levels of glucocorticoids or corticosteroids, is that we end up with muscle loss. Now, when we have muscle loss, you know, one of the side effects is our BMR, which is our basic metabolic rate, the speed at which we burn calories reduces. In other words, we start gaining weight, right? We're losing muscle. That leads to weight gain. But muscle weakness from muscle loss also increases pain. When we have muscle loss, we get or develop, you know, around the bend here, we get muscles tightening up. They're shrinking. They're atrophying. And so what do? We get joint compression. And when we have joint compression, when we go to walk, when we go to move, that increases our pain, right? And when we have pain, what do we do next? We stop moving. Most people guard from pain, so they are less active. They're sitting more. They're protecting themselves from activating that pain. This is especially true if that pain is in a joint or a muscle, because joint and muscle pain typically are increased in the areas when we move them. So we develop this kind of protective mechanism where we've either stopped moving altogether, and when you stop moving, what happens to muscles? They continue to waste further. So you get stuck right here. Muscle loss, weight gain, more pain, more atrophy, more weight gain, and you just stay stuck here. Well, the process of weight gain as well is also inflammatory, because a lot of that weight that we gain when we become sedentary is an inflammatory type of fat, and it's fat that stores around your heart, it stores around your viscera, and that type of fat increases the risk for strokes and heart attacks and other health issues. But again, this cycle is normal unless we do something to interrupt it. And so we can interrupt it up here by changing our diet, changing our lifestyle, right? There are a lot of things that we can do. We'll talk more about that in just a minute. But again, cutting grain out is one fantastic way to reduce overall pain. We've got case studies of people that within a week, within 2 weeks, had no more pain. Years of chronic pain, 10 years, 20 years of chronic pain, changed their diet, and within weeks, the pain is gone. So all that being said, I want you to understand this mechanism. We come back over here. The other thing that I want you to understand about cortisol, because again, this is one of the common drugs that doctors prescribe, is taking this drug over long periods of time chronically increases blood sugar. which increases the risk of diabetes. Diabetics don't heal, or they don't heal efficiently. And so they end up then developing other problems, and one of them is nerve pain. Then they go on to develop neuropathy or nerve pain, and now they're being treated for nerve pain too. And so this is when, pain management sets in. Now they've got this physical joint and muscle pain, then they've developed this long-term blood sugar problem that's led to nerve pain, and now they're being managed for nerve pain, and the nightmare never ends. You can see here excessive cortisol interferes with vitamin D, calcium, and magnesium, which we've talked about. We talked about a moment ago. It also, that lack of movement, when we stop moving, that lack of movement reduces the cerebrospinal fluid flow. Remember, part of movement is that it is a pumping action. When you walk, your spine is moving, and that pumps the cerebrospinal fluid movement around your brain. It helps your brain to detoxify. And so a lot of people, that when they stop exercising and stop moving, their brain starts to deteriorate at a faster rate, increased risk for things like dementia. We also know that pain medications, again, don't stop the influx of grain-based poisons, come with a plethora of detrimental side effects to include, as we've already talked about, death, addiction, intestinal erosion and leaky gut, and then nutritional deficiencies. These very nutritional deficiencies recreate this cycle ad infinitum, ad nauseum, and you're stuck. So don't get stuck. Now, let's talk about some additional things here I want to point out. So I mentioned earlier that corticosteroids cause muscle wasting. And so a lot of people challenge that, but I want to show you, this is just a research study published a few years ago. Patients treated with corticosteroids for various disease states such as arthritis, asthma, and chronic obstructive pulmonary disease. So remember, steroids also include your steroid inhalers, not just steroids for pain. Frequently suffer from muscle wasting as a side effect of the treatment. Okay, so this is a commonly known medical side effect of using those drugs long term. And as I asked earlier, how many of you, when your doctor prescribed that drug, told you that a side effect of that drug was that your muscles were going to start shrinking and wasting and creating more of a problem? Again, we'll look at those comments and see how many of you answered yes to that. Okay, let's look at this study here on diclofenac. Now, diclofenac, this is a type of NSAID, non-steroidal anti-inflammatory drug. And so a couple of studies on these types of medications, non-steroidal anti-inflammatories, where they looked at, in this case, it was called the DOLAR study, DOLAR Spanish for pain, but it's kind of unique the way they make these acronyms. But aside, lumbago means low back pain. And so DOLAR means pain. But this study, what they found is that when they combined diclofenac, which is an NSAID, with B vitamins, the outcomes were superior than just using diclofenac alone, right? And so they compared. They actually did two arms in this study where they said, okay, we're just going to give patients non-steroidal anti-inflammatories for their pain, or we're going to give them non-steroidal anti-inflammatory with B vitamins. Well, the B vitamin group did better. Why is that important? It's important to understand because you need B vitamins to deal with pain. B vitamin deficiency can contribute to pain, and this is one of the things, again, most doctors won't have a conversation with you about. When you go to pain management doctor, they're not handing you a B complex and saying, let's try this first. They go straight for the big guns. So this is another study on diclofenac, administration by B vitamins. You can see here in this study, the results document the positive influence of B vitamins on painful vertebral syndromes and indicate that B vitamins contribute to saving of NSAIDs by shortening the treatment time and reducing the need for the NSAID. In other words, the B vitamins work so well that they reduce how much of the NSAID the patient actually needs. So think about that in terms of how many people could need less of those types of drugs and get less of those types of symptoms associated with those drugs. And in this case, it was B1, B6, and B12 that was being used. We know that B12 deficiency can cause chronic pain. We know that B6 deficiency also is associated with pain. We know B1 deficiency, because of its role with acetylcholine and the nervous system, regulates how we interpret pain in a large way. So again, these B vitamins, very important, and research kind of shows that and backs it up. Now, I want to pull up this as well. I thought this would be important to show you. The role of vitamin C in the treatment of pain. You see here a number of recent clinical studies have shown that vitamin C administration to patients with chronic regional pain syndrome decreases their symptoms. Acute herpetic and post-herpetic neuralgia. This is chicken pox, okay? Or in some cases, doctors call it shingles, but it's post-herpetic neuralgia is the fancy way of saying it. Vitamin C administration also diminished pain in these patients. Furthermore, cancer-related pain is decreased with high-dose vitamin C, contributing to enhanced patient quality of life. Overall, vitamin C appears to be safe and effective adjunctive therapy for acute and chronic pain relief in specific pain groups. I think it's important that you understand that for a couple of different reasons. Number one, NSAIDs, as we said before, reduce vitamin C. Steroids also reduce vitamin C. Go back to what we've already learned. These are two of the most common medications prescribed for the management of pain, and both of those medicines reduce vitamin C, and vitamin C can reduce pain in people that struggle with chronic pain syndromes. As a matter of fact, in my practice, vitamin C is one of my favorite things to use at high doses for people that struggle with chronic pain. 5 grams or more per day is where I generally start people who are in chronic pain. We also add to this combo, we add quercetin, generally 2 to 4 grams per day. In many cases, one of the ways I help people wean off of these medications is with this combination. So if you find yourself there, talk to your doctor about that combination and what it might be able to do for you. Something else I wanted to point out is this study on the supplementation of vitamin D and calcium in patients suffering from chronic nonspecific musculoskeletal pain. And you can see here the conclusion of the study: supplementation with vitamin D and calcium decreases chronic nonspecific musculoskeletal pain. Again, let's tie that back to what we just said with steroids. Not so much NSAIDs here, but steroids reduce vitamin D and they reduce calcium. We said that earlier. And here we have research showing that using calcium and vitamin D reduces nonspecific musculoskeletal pain in patients. So if you're being treated for nonspecific musculoskeletal pain with a steroid that's depleting vitamin D and calcium, you could be making the problem worse. So again, I'm trying to draw a lot of inference for you guys on the loops, the kind of progressive loops of futility that medicine commonly throws at people when they're dealing with chronic pain. The pain management is probably one of the most archaic forms of medical treatment today because they don't respect nutrition. They don't understand that the very drugs they're trying to use to treat the issues are the very things that are potentially perpetuating the issues. Okay, let's move into nerve pain. Now, nerve pain is a little bit different in terms of some of the mechanisms. We won't get into the details of that, but these are common drugs. Aside from, now many doctors will also use steroids and they will also use non-steroidal anti-inflammatories to treat nerve pain. But these are some drugs specifically that are used to treat nerve pain as well, very commonly. Tricyclic antidepressants, so the class of antidepressant medications oftentimes have an impact on people's perception of pain, and there are a lot of different examples here, amitriptyline being one of the more common ones. And you can see these medications cause vitamin B2 deficiency and CoQ10 deficiency. Now, why is that important? Is that CoQ10 deficiency causes myalgia, muscle pain. Vitamin B2 deficiency can also cause myalgia. So again, using these medicines long-term chronically can cause muscle pain. Now that's different than nerve pain. So you're treating your nerve pain and you're trading it for muscle pain. And that's again another example of a loop we want to try to avoid. We also see a lot of times doctors will use the class of medications called SSRIs, selective serotonin reuptake inhibitors, as well as selective norepinephrine reuptake inhibitors. And so examples here, venlafaxine, duloxetine, citalopram, etc. these medicines cause vitamin D and calcium deficiency. Now, what we just said a moment ago about vitamin D and calcium is that for nonspecific musculoskeletal pain, these nutrients work to help relieve pain. So again, coming back up to that, these deficiencies, you're trading nerve pain for muscle pain. So you want to be aware of that. Again, have the conversation with your doctor about the nutritional depletions that can be caused by those, and make sure, even if your doctor's ignoring it, that you're not. You don't have to sit on the sideline and let your doctor run and call all the shots. You should be the quarterback of your health. If your doctor's the quarterback of your health, just know this: he doesn't care about you or love you more than you do. So you're probably going to occupy 5 minutes of his time when you're in the appointment, and beyond that appointment, you're probably not occupying any degree of his mind or his mind space. Now let's talk about some of the other common medications used to treat nerve pain: anticonvulsants. And so these are drugs typically used to treat seizure, but doctors have started to use them also to treat different types of nerve pain. Some of the more common ones used nowadays, like gabapentin or pregabalin or Lyrica, these are drugs that affect the nervous system through varying degrees, but they're more classified as anticonvulsants really than they are as pain medications, but they're being used for people with nerve pain. Now, these classes of medications have a lot of issues too. They can deplete calcium, carnitine, vitamin D, vitamin K, B vitamins like 1, 3, 6, and 12, and folate and biotin are also B vitamins, as well as inositol. So this is a pretty long list of nutritional deficiencies, and we know that, as we've already talked about during the show, calcium deficiency increases pain, vitamin D deficiency increases pain, B vitamin deficiency increases pain. In my experience, inositol deficiency increases pain. It also causes reduced thyroid function. Reduced thyroid function leads to muscle loss and atrophy, which also increases pain, as I showed you earlier. So there's kind of a whole correlation of things that can happen downstream from these nutritional deficiencies. We also know that carnitine deficiency can cause myalgia, muscle pain. Carnitine being a very important nutrient. It's the taxi cab or the shuttle for fat, so it helps your body burn fat as energy. A lot of people going on ketogenic diets need more carnitine in their diet to burn that fat as fuel. But these medicines cause or can contribute to carnitine deficiency, so it's important that you understand that connection. Okay, let's see here. Oh, I want to back up just a little bit. I had some other studies I wanted to talk to you about. So here we have, I was talking about SSRIs a moment ago. I want to make just make an observation for you about this class of medications. This is a very common prescribed drug, and even if you don't have chronic pain, a lot of you may have been prescribed this drug to treat depression or anxiety, because it's more commonly used to treat those types of situations or conditions. But you see here in this study, and there have been a number of studies demonstrating this, but this particular one was a systemic review and meta-analysis of many different studies, finding that this class of medications, SSRIs, demonstrate the use of these drugs, associated with lower BMD values. That's bone mineral density. And the reason I'm pointing this out, some of you may think, well, what does bone mineral density have to do with pain? Well, if you're taking a drug to treat your pain that causes your bone to become less dense, then you increase the risk for things like bone pain and bone fracture, which will also hurt. And so again, you're opening yourself up. So we said some of these other drugs cause muscle loss. And now we're saying some of them cause bone loss. So that's your musculoskeletal system basically being deteriorated by the very drugs that you're taking to try to reduce the pain of your musculoskeletal system. To me, again, it's a loop. You don't want to get stuck in that loop. If you can prevent it, if you understand it, you can make intelligent decisions about how you want to deal with it and not just rely on your doctor to tell you, oh, don't worry about the side effects. Those are so rare. What's what we always hear? The side effects are rare. How many of you have ever been told, oh, don't worry about the side effects. The side effects are rare. Type that in below. Share with me if that's something your doctor's told you, and then you went home and then proceeded to have the very side effects that were so rare. But last thing I want to talk about is the influence of dietary supplementation on neuropathic pain. This was a major review published a few years ago. And I think it's important to point out because so many, again, doctors ignore this, and they shouldn't, because the power of nutrition and nutrients to address pain is very, very prolific. You see here several pharmacologic approaches exist for nerve pain. However, they can lead to numerous adverse effects. It's what we just talked about. From this perspective, the use of nutraceuticals and diet supplements can be helpful in relief of neuropathic pain and related symptoms. In this review, we discuss how diet can radically affect peripheral neuropathy, and we focus on the potential approaches to ameliorate this condition, such as the use of numerous nutritional supplements or probiotics. Now, I'm not going to get into the entirety of what they talked about in this review. I will say this: if you're really struggling with neurological pain, you want to consider alpha lipoic acid. You want to definitely consider a B complex. Those are safe to take. They're not going to harm you. They're not going to interfere with your medications. Relatively inexpensive to do and can have profound impacts. Now, you might also consider calcium, magnesium, vitamin D, vitamin C, vitamin E, quercetin and other bioflavonoids. And you might also consider CBD if you have or struggle with these pains. These are all fantastic supplements that can play major supportive roles and help you out of this bind. Now, that being said, I've done a full comprehensive video on this very topic. You can check that video out right here. I also invite you to watch the rest of this series on drug-induced nutritional deficiencies from commonly prescribed medications. You can check that out down here. Thanks so much for tuning into Dr. Osborne's Zone. Make sure you share this with 10 other people you know, because together we can get this information out and help save lives and change the world.